right. Thanks, Kingman. So hope you can all hear me well. I apologize. I don't have a virtual background. My computer's processor is too slow, so you got to stare at my messy office. Just try and ignore that. These are disclosures, just a couple sections for up to date, and that I'm chair of the ABIM Sleep Medicine Exam Committee, and there will be no exam questions. I have to say that every time I give a talk during this talk. So what I want to do in about the next 55 minutes is cover these areas. So it's focusing really on the post-stroke patients. So we're going to review epidemiology of sleep apnea in those patient populations, the consequences, diagnostic strategies, and treatment. I actually got interested in this quite a while ago. I was pulling up, I've got a series of slide decks going back over 15 years because we have a big PM&R service here, as you guys are likely aware, and they take a lot of the patients that come in with strokes that need inpatient rehab, and so they're interested in hearing about sleep apnea, and literature starting to come out about that time about the post-stroke patients. So I've been lecturing to them on and off over this time, and then developed some protocols and have done a little bit of work in this area myself, even though I'm not a neurologist. But it has been an interest of mine, and it's kind of tailored in or dubbed into this Sleep Smart study we're going to talk about at the end, which is a large multi-center study that we're trying to get up and running with here. I'm not sure, is UH involved with that at all? Does anybody know? No, Sleep Smart? No. Well, anyway, in any event, so we'll talk about that at the end. It's something being driven by some neurologists at the University of Michigan. So you guys all know about the prevalence information about sleep apnea in the general population. The best data comes from the Wisconsin Sleep Cohort. Back in the 90s, it was 2 and 4%. Most recently, it's 5 and 14%. It's probably higher than this now. And again, the thing to emphasize with this study, these are community dwellers. It's not a clinical population. And so when we're dealing with patients that are we're seeing clinically that come to our clinic, we see in the hospital, the rates are going to be higher. We've done surveys in the past, so it's been probably over a decade, and I'm sure the numbers are higher at this point. But at that time, it was around 30% of patients would be considered high risk for sleep apnea in the internal medicine population. And then specific populations have very high prevalences. I'm sure everybody knows, the bariatric patient population. You study them, and the hit rate's going to be 70–80%. You look at the cardiovascular population, the heart failure, and the AFib populations, you're going to be finding 67% have some form of sleep disorder breathing. Well, it turns out the post-stroke patient population is also part of this mix. So these are some early studies done back in the 90s and the early 2000s, and showing, hopefully you guys can see my pointer here. But for some reason, as you'll see, a lot of the post-stroke patients, they seem to focus on a HI of 10 for whatever reason as a cutoff, not 5 or 15, which we often use. But you can see these are patients that were studied usually in the subacute setting, so within the first 2 to 3 weeks after their stroke. You can see that using an HI 10, hit rates are 60 to 70% of them have sleep apnea. The orange bars represent age-matched controls. And then there's been enough studies now looking at this. This is a meta-analysis now 10 years old. There's been a more recent one about 5 years old that really showed the same information. But you can see here, this is a whole variety of studies showing on average, when you get down here, that about 60% of patients who've had a stroke have obstructive sleep apnea, as defined again by an HI of more than 10. And some interesting things come out of this study as well. So if you do look at the HI of 5, which we traditionally would use as the cutoff, it's 72%. If you want to look at severe patients, it's about a third of them have, or patients, about a third of the OSA, a third of the post-stroke patients have severe OSA, but only 7% have central. So the majority of these patients that have sleep disorder breathing is going to be obstructive in nature. And one other thing to highlight here is that a number of these studies actually looked at TIA patients, not just stroke. So that gets into an issue of sort of which came first. So for a long time, when information was originally coming out about this, there was a lot of debate. Well, a stroke probably has led to sleep disorder breathing. But I think everybody sort of agreed upon and settled upon that's probably not the case. It's probably what you're looking at as an enriched patient population. And most of these patients probably have had untreated sleep disorder breathing, and now you're looking at a bad outcome. So it's really a population that's just enriched for the underlying risk factor, just like you look at for hypertension or other risk factors for stroke. So some of the proof of concept, if patients have TIAs, they have this same rate of sleep apnea as those who've had a stroke. So TIA obviously doesn't cause any neurologic damage, so it's not going to affect any controlled breathing. If you look at patients, and I'll show you some data, patients who have OSA found in the post-stroke period, and then you test these patients serially over time as they recover from their stroke, there is some improvement, but it's pretty minor. When improvement is seen, it appears to be related to these factors. So dysphagia, that gets better. So patients, their stroke results in dysphagia. As that improves, their sleep-disordered breathing may get better, although most time is not going to resolve. If they do have central sleep apnea, which I mentioned is the minority of the patients, there may be some improvement in that over time. Patients with hemorrhagic strokes, I'm not going to get into. There is some increasing literature, although it's still a very small body compared to the obstructive patients, compared to the ischemic patients. So patients who have hemorrhagic strokes, if those improve, their sleep disorder breathing may get better. And then there may be some positional component to this as well. Oh, that's not quite as clear. So this is data again from a few studies early on looking at paired studies. So these were done in the subacute in the light blue or aqua blue. And then the kind of more purplish color here is after repeating the sleep study 3 to 6 months later. And these are on average, their average AHI. So you see improvement, they're statistically significant, but really these are clinically insignificant. Going from an AHI of 35 down to 24, they still have, moderate to severe OSA, same with the rest of these studies. The last study here with the gold bar, this just has a control population that's age, BMI, and gender matched, just for reference. So some of the slides here from talks I give around the institution and to other specialty docs, so you guys are aware of this. But this just to sort of hit home that sleep apnea is associated with increased mortality. This comes from the Sleep Heart Health Study, one of the best studies done because it's large. Looking up here on the right, you see 340 patients in HI over 30. There's almost no studies that have that kind of number. I like to highlight the 5-year survival rate here. So you see patients without OSA in the top, and then as you go down, there's a dose-response relationship going from mild to moderate to severe OSA. And just to drive it home a little bit further, everybody advocates for screening for breast cancer and prostate cancer. That's kind of no-brainers. Severe OSA, which is not advocated for screening, has a worse survival rate of 5 years in those two conditions. So what do we know about patients who've had a stroke and then are found to have sleep apnea? Are they at risk for increased mortality? So this is a meta-analysis from 2014. You see down here in the left corner, not huge studies, 90 to 166 patients. And there's huge variability in the follow-up. So half a year, it can be hard to find probably a big mortality benefit or change there, but out to 10 years. All these studies were statistically significant with the exception of 2. So this top one here by Bassetti did not find a statistically significant difference in mortality using HI 30 and then 10. But there's clearly a trend in the mortality in the OSA. Patients found to have OSA was 22% versus 9%, but did not have significance. Same with this study by Rolla. They used just the 5 cutoff, AHI 5. But they only had 6 patients die in the whole study, so that's probably not all that helpful. But then the best study is this study by Celine, which they adjusted for 9 risk factors. None of the other studies did adjusting. They used a 3% definition for hypopnea, so that's important to note. And they used an HI cutoff of 15, and this was statistically significant increase in mortality for those with sleep apnea up to 70% higher. So when you pool all this data, it does show about 70% increased risk of mortality for patients who have had a stroke and are found to have OSA compared to patients who've had a stroke that do not have OSA. Again, so we know sleep apnea harms patients. It's linked to a lot of comorbid conditions and thought to be that OSA is in part at least driving the underlying pathophysiology associated with the development of these conditions, hypertension, coronary disease. But I want to focus specifically on arrhythmias and then secondary strokes. So you guys are probably familiar with this literature. This is a meta-analysis now almost 10 years old, looking at patients that have had PSG diagnosed sleep apnea and then have atrial fibrillation, and they undergo an ablation for that atrial fibrillation. So if their OSA is, if they have OSA, their rates of going back in atrial fibrillation are significantly higher, up to 50% higher here. So in the blue box, that highlights the PSG studies. It's not noted if you just do questionnaire screening. But if patients are diagnosed with OSA and they have AFib and they get cardioverted or ablated, their rate of going back into AFib over time significantly increases. And there's been studies suggesting that if you treat the sleep apnea, that rate goes down. So, why they're throwing about AFib? So this is an interesting study that looked at the link between AFib, sleep apnea, and stroke. And it's kind of interesting. So it was a retrospective chart review where they looked at 1,000 records of patients coded as having a stroke. One of the most interesting findings of this is that almost all the patients were excluded because they didn't have a stroke, which makes you a little worried about ICD-9 codes. So they only had 50 patients that were included in the study, and then these patients all had a PSG in the year prior to their stroke. So this is looking at their PSG database. And you can see that they used HI-10 as a cutoff again. So 30 had OSA and the stroke, and then 21 had a stroke but no OSA. And interesting, what they found was that the majority of the patients that had a stroke who had OSA, in the black bar here, was because cardioembolic. So I was a little surprised when I first saw this. I thought, because I was always thinking, along the lines more of, we know that sleep apnea causes vascular disease. There's a lot of data about, changes in carotid intimal thickness and, small vessel disease. And so I thought that might be the major driver, but actually is not, at least according to this data, that suggesting more that OSA is leading to stroke, perhaps mediated through the development of atrial fibrillation. Some subsequent work did show the mean nocturnal oxygen saturation is associated with AFib in stroke patients. Again, so suggesting a tie-in there as well. So what about sleep apnea in a post-stroke patient? Does it increase their risk of having a secondary stroke? So this is again a meta-analysis 2014. So there's a few studies that have looked at this. Two of the studies were not statistically significant, but the biggest driver was the Martinez study, which was the largest and best well-done study. And that did suggest that the patients who have sleep disorder breathing found post-stroke, they're at higher risk of having a secondary stroke compared to those that do not have obstructive sleep apnea. And then we all know that sleep apnea is associated with depression, anxiety, irritability, can affect those things. All problems, particularly depression in a post-stroke patient, we know about post-stroke depression. Social and sexual function can also be impaired. And then sleep apnea in and of itself causes neurocognitive impairment. It can affect white matter changes. There's been multiple studies looking at this, affecting not just learning and memory, but attention, information processing. All will be bad when you're trying to recover from a stroke. So you think about the brain trying to heal itself, and if you're having intermittent hypoxia for a third of the day, that's going to be problematic in terms of the brain recovering, and particularly affecting these functions. So this study was 80 patients with a stroke who had sleep disorder breathing, compared to 67 patients with a stroke that did not. They used an HI of 15. And as expected, the ODI and AHI were much higher, 33 versus 3 than the controls. Patients with sleep disorder breathing were a little bit older and a little bit heavier. Note the BMI, that was only 27. We'll come back to that in a minute. But what they did was they just looked at, this was a cross-sectional study. So the patients, when they hit their rehab floor, they just said, okay, let's see how well these patients are doing in terms of cognitive and functional outcomes. And what you can see is that patients who were diagnosed with sleep disorder breathing after their stroke, that they're at that point in time in the subacute period, they had significant decrements compared to patients who did not have OSA in attention, executive functioning, visual perception, psychomotor ability, and intelligence. All things that I just mentioned in the previous slide. Likewise, with functional outcomes, their functional outcomes, their status at the time when they did this was worse. So everything was statistically significant, with the exception of the NIH stroke scale score, which was higher in patients who had OSA, but did not reach significance. So that's a point in time, but if you look, there's actually quite a bit of data going back, looking at how these patients actually recover over time. So this was one of the earliest studies done where they used a Barthel index, which is a functional measure of improvement. And they looked at patients who had a stroke, and they were admitted to the inpatient service, and then they followed these patients to see what happened with their Barthel index over time. And they just did oximetry screening. So they use an ODI 4% cutoff. So again, using 10 as their cutoff. But in patients, so you're assuming that ODI 4% less than 10, they likely do not have significant sleep disorder breathing. Their improvement over time, so even in the first few weeks, it was statistically significant. So it's their time on the rehab service. Their functional improvement was much better than those that had a high ODI. And then that persisted out to a year out. We actually did a similar study at Metro back when I was first getting interested in this, and unfortunately we never published this. I'm not sure why, but they used the FIM index here on the PM&R service, so it's functional independent measure. And basically the higher your FIM improvement is over your 3 weeks on the rehab, the better off you have done. We use just oximetry. At this time we were starting to do oximetry screening of our patients. We were just using an ODI 3%, so not the 4%, but 3%. And then we broke out the patients based on, 3 weeks, 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 3 we into quintiles based on their ODIs. And so you can see really these first two groups at 0.1 and 2 would not be considered to have sleep disorder breathing, but 5 would be mild, 10 is probably in the moderate category, and 35 is going to be severe. And you can see that all those patients with sleep disorder breathing, their functional improvement was not near as robust as the patients that did not have, presumably did not have sleep disorder breathing. So we know sleep apnea is underdiagnosed. Again, those numbers, so if you talk about HI5 with symptoms, 5 and 14, HI more than 15 in the general population, 6 and 13. So again, this is almost a decade old now, though. This is a study we did at Metro just to look at the outpatient setting. So we know that docs are missing it. This is, I'm sure, still happening, as we're all aware. Where we actually took 100 patients that came into our family practice clinic, and when they were coming out of the family practice clinic, we just gave them some questionnaires to determine what their risk of various sleep disorder sleep disorders was. And what you see in the patients, we used a STOP questionnaire as well as a Berlin questionnaire, which is why you have two different measures here. About a third of the patients would be considered high risk for having sleep disorder breathing. These things have positive predictive values around 0.8 to 0.9, so these are going to be fairly accurate. However, when we compared it to the went back in the charts to look to see, these were all new patients being seen, how often the docs had actually taken any history, anything in their review of systems, anything in their assessment plan, finding only that 2 of the patients were actually labeled as considering to have OSA, and 1 already had a diagnosis, and the other one, the doc suspected it. So they're missing a lot of these patients in the outpatient setting. This is not unique to Metro. This happens universally. There's been other studies by various methodologies showing that. In the inpatient setting, this was a study that we did. We did PSGs on patients just admitted to the general medical floor for a whole variety of conditions, not coming to the ICU or out of the step-down unit, but just to the general medical floor. And we found that 40% of the patients would have had an HI more than 15. And again, it's not suspected by the inpatient teams. Only 2 of the patients were suspected of having sleep disorder breathing. So, you know, that's 2 of roughly 35 or 40 patients had an HI more than 15. So it's missed in the outpatient setting, it's missed in the inpatient setting. So it's generally going to be missed, which is why a lot of these patients are presenting. So this is an interesting study Devin Brown did using a database. I can't remember what it's called. It was some sort of brain attack database. It was in Texas, in Corpus Christi. And they analyzed what happened with these patients, 980 patients coming in with strokes at a single academic center. And 17%, that's it, were offered sleep testing prior to their stroke. But after their stroke, almost nobody asked questions about sleep apnea. So 5% asked about snoring, not 10% sleepiness, 6% were offered a PSG. So, you know, this was published 2019, the database went up to 2015. So even at that time, despite a lot of this information, which has been around now for over 20 years, it's not on the radar screen. So again, this is a slide from a PCP talk. When should you screen for it? Only when we or the patient think of it, you know, that's kind of bad. Actually had, and this has been one of the problems at Metro, our neurology department has never really been all that interested in sleep apnea in the post-stroke patient. And when I approached them about this issue, one of my neurology colleagues said, well, okay, yeah, so I'll see if they want to use CPAP. If they want to use CPAP, then I'll send them for a sleep study. And I was like, okay, we're not going to get very far with you. You know, those in high-risk groups, everyone, you know, currently CDC, US Preventive Task Force, and the American Academy of Family Practitioners do not recommend routine screening. But there's, you know, opinion articles going back to 2006. This is from Madeline Griggs-Damberger, said why a PSG should become part of a diagnostic evaluation every stroke in TIA. So nobody, you know, bats an eye when we talk about, oh, you know, stroke comes in and you need to get an echo, you need to get carotid Dopplers, you know, all that stuff. You know, why aren't we getting a PSG on these patients? Your hit rate for something is going to be much, much higher for sleep apnea than will be for finding something on the echo or the carotid Dopplers. The ASM recommendation for PCP screening, they actually do list if they've had a stroke as being a high risk and that those patients should be screened for sleep apnea. They don't actually say they have to have a sleep study, but you need to at least screen it, whether that's history or screening questionnaires. So, which gets into a problem. So we all know about, again, this is a PCP slide, the symptoms of sleep apnea, snoring, choking, daytime symptoms of sleepiness. Those are sort of our hallmark symptoms. Then you have the mood effects, and we talked about some of this already. Problem is this post-stroke patient population may not present like your typical sleep apnea patient. So this is a study in which they compared 100 patients with stroke to 1,000 controls. All of them had PSGs, and they labeled them using the HI cutoff of 4%. into no sleep apnea, mild sleep apnea, or moderate sleep apnea. I have here that 17% of the controls had mild, 33% of the stroke patients. 11% of the controls had moderate to severe, and 19% of the stroke. So again, that kind of is in line with the other data, over 50% of the patients having at least a mild sleep disorder breathing. When we look down at their Epworth Sleepiness Scale score, the second value are the patients here in red are the patients who had a stroke. So even for mild sleep apnea, their Epworths on average were 6. For moderate severe, it was only 7. So these are normal values. So these patients typically are not sleepy. In addition, and I kind of mentioned this earlier, their BMIs are not, they're not typically obese patients either. So BMIs are 29 and 27. Even for the moderate severe, their BMIs are only 27 on average. So it's a little bit understandable why these patients can be missed, because if you do your routine things and put risk stratify patients by the classic criteria used for everybody else with OSA, you're going to miss these patients because they're not sleepy and they're not typically obese. What about the stroke location? Does it correlate at all with sleep apnea? So that kind of goes back to some of the earlier thoughts that the stroke may be contributing to the sleep disorder breathing. But it turns out no. So if you look at these p-values, this is OSA prevalence unadjusted and adjusted. Doesn't matter where the stroke location is on the left panel here. None of these were correlated with the presence of sleep disorder breathing, and none of those correlated with the AHI either. So it doesn't matter where your stroke is, there's no correlation with that in the sleep disorder breathing. So what can we do about sort of identifying these patients? So, you know, one of the first things most people reach for is how can we screen for this, so they're not having to get objective studies on everybody. So the cheapest way might be to do some screening questionnaires. So there's been some studies that have looked at this. Over in the left panel, they have the Berlin questionnaire, stop bag, which just takes out the neck circumference. Stop bag 2 is also just taking out the neck circumference. And that was a study from the Cleveland Clinic. And then the sleep inventory, which takes into effect gender, LV ejection fraction, their sleepiness on the Epworth, neck circumference. And P was, I forgot I wrote down, weight in pounds, diabetes, and then their night stroke scale. So you can see variable sensitivity. So the latter 3 seem to be reasonably sensitive, but their specificity is pretty poor. So that creates some problems with screening these patients. They make up positive predictive values. You know, they're not, some of them are okay, but not great, 80%. So I think, and then the sleep inventory had the best thing about it was a negative predictive value of 100%. So the problem with a lot of these screening tools, you are going to still miss a fair number of patients. So it gets to the issue, should we do some sort of objective testing? So you all know about obviously the tests that we have available. So PSG remains our gold standard. You know, the obvious advantages to that, you get comprehensive data, you can determine, you know, stage related, body position related. If it's attended, it's going to be observed. They can troubleshoot, and particularly in a post-stroke patient, that may be important. But it's costly. There's limited access, and you know, when are you going to study these patients? Doing inpatient sleep studies is very difficult. Doing on the rehab service, which is what we had started doing, because of the convenience that we actually had a sleep lab over at the same building, although that's since disappeared. So it's not readily available to us either. So there's some definite problems with doing a full PSG in these patients in a timely fashion. And then again, you know, the big thing you get out of here is the AHI, but people forget that, you know, the AHI is, and we talked about this, I think, before in grand rounds, it's really not the best parameter. We need better parameters. These are just 3 oximetry examples of patients with severe OSA by their AHI. So all similar AHIs, but you can see this top one, this patient's mostly having probably hypopneas with arousal, and in this bottom one, they're just probably having apnea with severe DSAT, apnea with severe DSAT. So their AHIs may actually be similar, but their ODIs and the time spent with low SATs is very different. So it brings up the issue, could you get by with, you know, less aggressive testing? So HSATs do hold promise in this area. So these are, you know, going to be limited, unattended studies. They're less costly. You can do them in the home, or you can do them on the floor more easily. Obviously, you get limited data, so there's some problems with that. No technical support, so if a lead does come off during the night, then the study's kind of a waste. They're not always standardized, and then they do have a non-trivial false negative rate, although for this patient population, may not necessarily be quite as important. So I was part of the diagnostic task force, diagnostic testing task force, the ASM, back in 2017, I think we published it. And at that point, we said that patients, there were certain patient populations in which PSG still sort of was the preferred test. So, obviously patients at risk for central apnea, those patients at risk for hypoventilation. And the post-stroke patients actually kind of fit into that category. So recently I was asked to review this literature again, and it's kind of surprising that there really is a paucity of data for comparing home sleep apnea testing, which a lot of studies are utilizing and reporting on in the research literature, but just they have not been validated. So we went back and looked at this and did a literature search to try and find it. And there are some studies, but a lot of the studies, there are a few other studies that are mentioned here, but the other studies generally are feasibility studies. We're not actually comparing to PSG, or there's a methodologic problem where they take certain leads off the PSG and they mimic a home study and say, oh, look, this is adequate. When in point of fact, that's not the same as doing an HSAT. So there's one study that HSAT and PSG categorized as a level 2B study. I'll show you that data here in a second. But it was only limited to 21 patients. So there's really a need to validate these devices in this patient population. A lot of researchers are using these devices and assuming that they're accurate, but we don't actually know. And there's such a huge spectrum and variety of devices out there that it does create some problems. So this was from that one study. So they used Embleta. They used a 4% desaturation, and that's important to recognize here because that probably plays a role in a lot of the accuracy of the testing. But you can see these ROC curves are actually pretty good for more than 5, more than 15, and more than 30. But again, a very small study. So it's a single small study suggesting possibly some utility, at least for the Embleta, utilizing the 4% desaturation criteria. So I guess the issue of oximetry. So what about doing just very simple oximetry on these patients? So there are some advantages. Very cheap. You can do it anywhere. Most of the time you are going to get reliable information because you just have a pulse ox on them. But you get limited data. There's no technical support. As Dr. Stroll has shown us from previous work done here in Cleveland, that interpretation is not standardized, and so you can run into problems with that. People interpreting these in a huge variety of ways. There can be false negatives, so particularly if you're looking at using arousals and 3% DSATs to define your sleep disorder breathing. And unfortunately, you can't make a formal diagnosis of OSA. We all know that. You can't get treatment based on just an oximetry. So even if you do this as a risk stratifying tool, you have to do something else in order to get the patient therapy, at least for homegoing purposes. So as part of the recent review, we did look at oximetry, and there's actually more studies that have looked at this than there are HSATs and comparing them to PSG. But again, there's a lot of limitations to these, the data that's available. So again, most of them are using the 4% desaturation rule. And then some were using the oximetry off the PSG, which is problematic. It's not the same thing. So we still recommended against it. This is one of the better done studies, which was comparing the HI here in the left panel to the ODI on the top row. And you have sensitivity and specificity for various cutoffs for the ODI. So you can see, for an HI more than 15, that the sensitivity and specificity by the ODI, so you use an ODI of 5 for HI more than 15 is pretty sensitive. And then the higher the ODI, the more specific it becomes. But again, this is using a 4% desaturation. So this is not going to catch your 3% patients. And I already showed you some data suggesting that the 3% may be at risk for poorer outcomes as well. It's not going to catch patients whose sleep disorder breathing is manifest primarily with arousals and not desaturations, which may not be as high as risk, but still probably are, because we know that those patients also have increased sympathetic activity during sleep. So talk about treatment. So treatment of sleep disorder breathing in these patients, Cpap remains really still the primary treatment choice. There's a fair amount of data suggesting that initial acceptance is not too bad in terms of what you compare to the general patient population, 50 to 75%. Obviously, some patients are, they come with one acute illness and they find they get another one, and they may be somewhat less reluctant. You hear the story, I don't want to start this, I'm trying to focus on recovering from my stroke. But then there's been concerns about worse compliance in those that are elderly. They're less sleepy, so we know some compliance relates to how sleepy patients are, if they get an immediate benefit from resolution of sleepiness. And then they're likely to be less compliant the more severe their deficits are from their stroke. And there's one study that's a 5-year study suggesting overall compliance really is poor, down to 15% at 5 years. But a more recent study, which didn't go out, or actually did go out, I'm sorry, did go out to 5 years, did show some improvements. And this may be related in part to, better interfaces, use of heated tubing, heat humidification, et cetera. But their post-prescription usage at 3, 6, 12, 24, 60 months, which is 5 years, 58, 53, and still around 40% at 5 years. So actually not bad and not too much worse than sort of the general population. But again, I think it takes, it takes some effort to make this happen. So do we know if Cpap is effective? So I talked about its compliance. So there actually been a number of small randomized controlled trials using different methodologies, but they have all shown benefit with Cpap for the post-stroke patient that's subsequently diagnosed with sleep disorder breathing. So this first study here is a multi-center randomized controlled trial of post-stroke patients. And it's interesting, they didn't do a PSG or HSAT when they started. They just randomized into autopap or no autopap, and then looked at 30-day outcomes. So they started the autopap within 2 days of admission, so it's pretty aggressive. And they found that there's generally good, what they call tolerance, with 63% being compliant. I think that was by the 4 hours, 70% of nights. And they showed that patients who use their Cpap had improvement compared to the usual control group, had better improvement in their NIH score. And the more patients use their Cpap, the better their NIH score, or there's a correlation with that. Against a tiny study, 16 versus 15 patients. Another study in the subacute setting, this is 44 patients post-stroke, sleep disorder breathing by PSG using HI of 15. And this was a 3% definition in this study. They did this once they hit the rehab service. So they come to the hospital, they have their stroke, they get stabilized, and they get sent over to rehab. And they compared Cpap and usual care to just usual care. And they showed improved functional and motor outcomes after 1 month, but there was no change in neurocognitive. So both these studies suggest improvements in the functional component. But again, very small study, 44 patients. So another one, subacute study, again, like the first one, did not do any kind of objective testing. They just slapped them on Cpap or sham Cpap. So again, only 40 patients total, but they looked at a month out. And they showed improvements in cognitive function. This is by the FIM, which can be broken out into the both cognitive and motor. They showed improvements in the cognitive function, but not in the motor. And that was whether by intention to treat or on treatment analysis, hovering right around the statistical significance cutoff. And this last study, these were patients, they did a limited channel study, and they used an REI greater than 15. Again, randomized to Cpap usual care for a month. Again, very small study, 20 and 16 in each group. The graph down here shows the dark bar are patients treated with Cpap, the light gray are patients that got usual care, and then the dashed line are patients that were non-OSA post-stroke patients. So you can see in terms of attention, memory, and executive functioning that the Cpap group was very similar and statistically significantly better. So similar to the non-OSA patients, statistically significantly better than the control patients that did not get Cpap that had OSA. Again, suggesting some cognitive improvement. So 2 studies suggesting functional improvement, 2 studies suggesting cognitive improvement, all very small, but all randomized controlled trials. Looking more long-term, the impact of Cpap on incident CVA and stroke-related mortality. So we talked about that the OSA post-stroke is related to a higher rate of a second stroke and also a higher rate of mortality. So in terms of using Cpap, there's 3 studies that have looked at this over the long haul, and showing again, when you pool this data, and this most strong study was this Campos Rodriguez, which I'll show you, pooling the data, that there does appear to be a definite treatment benefit to being placed on Cpap. And then when you look at mortality, same sort of thing. They found a statistically significant improvement in mortality with patients that use Cpap post-stroke. Problem is, none of these were randomized controlled trials. These are all observational studies. So this is just the data from the this is Martinez study. Was that on the prior one? Guess it wasn't. But anyway, they looked at patients with HI of more than 20 post-stroke. They were offered Cpap, followed for 7 years out. And the group that clearly separates out in terms of cardiovascular event-free survival, so composite outcome. But the group that really fails here are those that have an HI more than 20 that were not treated with Cpap. the NHI more than 20 and treated CPAP, they look like those who have mild and moderate sleep disorder breathing or considered not to have sleep disorder breathing. Again, not randomized controlled data. And I'm not sure if anyone will do that over the long term with this population, although we are doing it in the more short term, which we'll come to in a minute with the Sleep Smart study. So, other treatment options we think about for patients with sleep disorder breathing, well, oral appliance is generally not going to be an option, right? So they take a while to fit and then adjust. Getting a post-stroke patient to do that's not going to be probably feasible. They're also going to be much more expensive, right? $2,000 to $4,000 upfront to buy something you're not sure if it's going to work. Probably not going to happen. You can't subject these patients to surgery. No surgeon's going to touch them that, take out their tonsils or do anything else. There's medication as adjunct. So, the post-stroke patient population, sometimes they will use stimulants to help with depression or just poor alertness. But again, if they have OSA, they should really only be used as an adjunct. There's some data suggesting that this may increase the risk of secondary stroke. Well, it's not entirely clear. That could be also in part related to their untreated sleep apnea. Nasal valves, those are really kind of dropped off the radar screen altogether anyway, so we're not going to use those. Hypoglossal nerve stimulator, no way that's going to be put in. Getting to Kingman and the CNEP, the negative pressure devices. So that will be an interesting thing to study in this population. Of course, the big concern here is that carotid disease. So the patients with sleep disorder breathing, particularly if they already have vascular disease, you'd have to be very, very careful using that. So I don't think anyone's going to reach for this in the near future for this patient population. Interestingly, there are a couple of studies about doing some other alternative treatments. So one is using oropharyngeal exercises. So they actually did a 6-week trial using that same protocol in the original publication that came out of, I think, was it Brazil? They did show improvement in the patients who had sleep disorder breathing, but the improvement, while statistically significant, is probably clinically not very relevant. Their HIs went from 20 down to 14, which is not that far off from just monitoring them over time. They did not have a control group. And then what about positioning? So this is one of Ron Chervin's studies. They looked at trying to just keep them off their backs and elevate their head of the bed. And they found that they were able to reduce supine sleep time by about 1/3. And their HIs improved, but just marginally, about 19–20%. So really not very effective therapies. So oxygen is your backup, but there's no data on this. Clearly prevent patients from getting hypoxic, but it doesn't necessarily prevent the aorta from collapsing or potential sympathetic surges. So it's not certainly recommended. I'm not aware of any studies that looked at that in the post-stroke patient population. So I'm going to just get into a couple of studies, but the summary at this point is that OSA is very common in the post-stroke patient population. It's likely part of the etiology in terms of why they had their strokes. They may not present in the typical fashion, so a lot of the screening tools that we traditionally rely on are not going to be very accurate in this patient population. It is associated with poor outcomes. There's multiple studies suggesting that recovery from stroke, as well as higher rates of recurrent stroke, high rates of mortality, and I didn't really show the data, but there's increased rates of depression as well. It can be diagnosed. We need some better data with the limited channel studies, but that's probably going to be the way to do this. And then treatment may improve post-stroke outcomes, but we really need better data. So, over the time, we sort of evolved this protocol, which we've been utilizing here for a while. So I just want to talk about that briefly, and then we'll talk about the Sleep Smart study. So in working with our rehab folks, as I mentioned earlier, our neurologists weren't particularly interested in this. So we went to our rehab folks and said, these patients being admitted to you, they're coming for a 3-week stay. Why don't we try and assess them while they're there? So back before a lot of this data was really coming out, we started doing overnight oximetries on these patients just to risk stratify them. So really looking for those that were desaturating significantly. And we said, okay, if they are, assess the patient for PAP therapy. And we left this up to the PM&R docs because their site is no longer at the main campus. So the main criteria used: if the patient's cooperative, agreeable, if they can handle their secretions, if they can remove a mask if needed, that offer them PAP therapy if their ODI was high enough. So we use the ODI cutoff using ODI 3% of 10 or more. So really focusing on the right panel here. So those are all the criteria initially. So if they had the oximetry, and our PMR has been very good about doing these within the first night or two when they get over to the rehab service. And if their ODI is more than 10, ignore this other part here. Then we offer them a trial auto PAP. It's 4 to 16. So one of the limitations here is we have the respiratory therapy set them up. It's not a sleep tech, so that creates some problems right there. But the devices are downloaded in the morning. and then with a repeat oximetry done at the same time. And that information is then sent to me. So because of the issue with standardization of interpretation of the oximetries, I just took this upon myself, and I've been doing this. I interpret all the oximetries in a standardized format, and then I look at the downloads. And then based off that, we decide if there's evidence of reasonable control based on the oximetry and the AutoPAP, and try to continue it during the remainder of their stay on the rehab service. And then try to get them while they're there, since they're there for 3 weeks. We previously were able to do PSGs, but then we resorted mostly to doing limited channel studies, get them diagnosed so they could potentially go home with therapy. So this is all done remotely, so I'd actually have to go over and see the patients. If the patients don't have a good response, oximetry is bad, the AutoPAP download is bad, then I try to make adjustments based on what I'm seeing. So a lot of times it's a leak issue. It's usually needing a better mask fit. Sometimes a pressure adjustment needs to be made if the OSA is very bad. But a lot of the patients we could get under control by just doing these simple steps. And then once they are sent out, then they should be discharged on appropriate therapy and then follow up in the sleep clinic. So one of the problems we had with just saying, okay, someone has sleep apnea initially, we were not doing anything, so just send them to sleep clinic, is almost none of these patients would come back. It was like 5%. We tracked it for a while. So I'd show you, of course, you always want to show your best data, but these are a couple of oximetry studies for some of the patients where we did intervene. So the top row here is the oximetry. The next row is the pulse or the heart rate, so we don't even really look at that. You see they had an ODI 3% of 46, so really pretty severe, and this person's desaturating down in the 70% range. Put them on AutoPAP, and next night, and you can see there's a marked improvement. Doesn't totally eliminate it, but it's a significant improvement. Their ODI is down to 10. Likewise, this is a patient probably having REM desaturations, right, dropping into the 70% range again. ODI is 33, put them on AutoPAP, reduce that down to 5. So big improvements. So, we think we're doing a good thing, right? So this data looks pretty interesting. And, there's data from those other very small randomized controlled trials. So a couple of years ago, a med student approached me, wanted to do a project, said, hey, why don't we look at this? Because we've got all this information on these patients who've had a stroke. We diagnosed with sleep disorder breathing by oximetry, and why don't we check and see what's going on with these folks? So we did that, and unfortunately, this is really kind of disappointing data. So we found that about half the patients would be considered high risk. So half the patients had about 54%, I think it was, had an ODI of more than 3% of more than 10. And then we categorized the high-risk patients into those that were high-risk adherent to treatment, and we initially did that by, and this was a best estimate. Unfortunately, we did not have downloads for their entire time on a rehab service, so some methodological issues, but based on nursing notes and RT notes, we determined, patients looked like they were using it, and then actually going through the flow sheets in their charts to see if they were using the CPAP for at least 4 hours on 70% of nights. So those were the adherent ones, and then we had the high risk that failed therapy. So these were patients that either just said, nope, not going to do it, or they used it but very sparingly. And this is just their background demographic information. You can see their FIM scores at the start were not statistically significant different. The big message was that their ODIs were markedly different at baseline, and the high-risk group was 29. And then on AutoPAP, on that initial night where they did the AutoPAP, it came down to 4 on average, so it looks pretty impressive. Unfortunately, again, most of the patients are not using PAP therapy. And then we did look, so the rehab service does the FIM at baseline, and they do it again at discharge at 3 months. And what you can see here, so the total FIM score, and then we broke it down to cognitive and motor. And we compared the blue line being the low-risk patients, low ODIs, and then we had the high-risk adherent and high-risk failing AutoPAP. And you can really see there's no statistically significant difference in any of their FIM scores. They all improved over their time during the rehab service, but none was better than the other. So one of the problems is obviously there's a lot of factors to be considered here. So one of my colleagues in PM&R did regression analysis on a subset. So we actually, to bump our numbers up a little bit, we said, okay, what about the patients just using the CPAP for half the nights? We'll consider them adherents. That got us up to 14. And then we compared it to some that were not compliant, and we had full sets of data on these folks who do a regression analysis. And we found that actually in this regression analysis, that the patients that were not adherent to therapy actually did a little better on their FIM scores in terms of improvement. That was statistically significant, although that's not clinically relevant according to my PM&R colleagues. And there was no difference seen in the change in the FIM subscores of motor or cognitive. So it was actually a negative study. But it was kind of interesting because it's a real world study. So it's taking out of the context of those randomized controlled trials where you have, a research team there, people focusing on them saying, you got to use your PAP and, we'll make adjustments and do whatever's necessary, and really, coaching these patients compared to what, we were doing, which was a real world feasibility practical study where we're using, the resources we have here to try and make this happen. And in that setting, it doesn't appear that it's actually making a difference. So that gets on to the Sleep Smart study, which I'll wrap up with here. So based on all that information I previously presented to you, there's a lot of data that we talked about, OSA, post-stroke, bad. There's some hints certainly suggesting that CPAP may be able to improve or alter some of those outcomes. And so this study was designed by Devin Brown and Ron Churva at University of Michigan. And basically what they wanted to really look at is CPAP, can it be used, is it feasible, and does it actually change outcomes? So there's this study is underway, and there's two arms to it. There's or two outcomes to it really. So a prevention trial and then a recovery trial is what they're calling it. So there's going to be patients with a stroke, newly diagnosed with OSA, so ischemic strokes, newly diagnosed with OSA, or they could be high-risk TIA also. And then they're going to look at a composite outcome of stroke, acute coronary syndrome, or death at 6 months. And they're going to compare patients that are randomized to auto-PAP to just usual care. The recovery trial is going to look at how these patients do in terms of their recovery from their stroke. So the primary outcome is going to be looking at a modified Rankin score. But there's a number of secondary recovery outcomes, also looking at the NIH stroke scale, their cognitive function by the MoCA, and then the quality of life measures. And these will all be at 3 months. So it's a 5-year study. There's going to be over 110 stroke centers part of the StrokeNet, and the study's up and running. So far, it's randomized, or it's enrolled over 900 patients, but randomized about 350. Inclusion criteria, so pretty simple. Need to be more than 18, have an ischemic stroke or a high-risk TIA. And then the obvious sort of exclusion criteria. So patients that have previously diagnosed OSA on PAP therapy are not to be included. And then a lot of factors related to their stroke, we're going to exclude them. So if they can't do basic ADLs, if they have issues with making CPAP, if you got a huge facial droop and you can't wear CPAP, if they just had cranial surgery related to their stroke, hemicraniectomy, you're not going to include them. And then other kind of standard PAP things, severe bullous disease, pneumothorax, hypotension, big nasal bleed, those sort of things are not going to be included, or if they're really hypoxic. And then the interesting one, the very last exclusion criteria is very relevant right now, is that they're in airborne precautions. So if they're COVID, they cannot be in the study. And so the way the study is set up, it's actually pretty simple in design. So the patients are going to get come in within, hopefully within 2 weeks of their stroke. So we don't do this when they're in their ICU or in the step-down unit, but once they've come out of there. Then they get a NOx3, and it's going to be the limited channel one, not measuring any sleep. And they have to have obstructive sleep apnea, again, using that HI cutoff of 10. The central apnea index has to be less than 50, so they can't have central apnea. If they meet this criteria and the patient agrees to continue, then they get a run-in night of auto-PAP. And so if they tolerate that auto-PAP, so this ideally should be done while they're in the hospital. If they tolerate that auto-PAP for more than 4 hours, then they are eligible for randomization to the long-term study, at which point they will get auto-PAP usual care versus just usual care. And then they can look at the 3-month outcomes as already delineated, and then the big 6-month outcomes. If they can't tolerate auto-PAP, they can reattempt it. If it depends, if there's an interface issue, if there's a leak issue, so we have to look at all that information the next day, see if something can be done, and then see if we can get them to tolerate and then get them randomized. But if they continue to fail, they will not go into the study at all. So the goal is really to try to determine, so the very large randomized multi-center study, determine is auto CPAP going to make a difference in outcomes with these patients. Now again, it only goes to 6 months, so it's not going to be prolonged study, so that may impact some of the prevention trial outcomes. But I think it'll be very interesting, and it'll give us information that is sorely needed. So we'll be changing our protocol here once we get up and running. We've been held up, COVID clearly caused problems in more ways than one, not just with enrolling patients, but before we put patients on auto-PAP, we need to have them COVID tested, which is not routine here, so we had to make sure we could pay for that. And our study coordinator just left, and so we got a new study coordinator. So we're hoping that by later this month, we can start actually enrolling patients in the study. So with that, I think I have a few minutes left for questions, so I will stop and be happy to take any any questions anyone has? Thank you.
Well, thank you, Dennis. Yeah, a couple mechanistic questions from Ted was asking about what is the relevant signal that sort of produces the adverse outcomes, and what do you want to, is it oxygen saturation, is it arousals, is it heart rate, what might it be?
Yeah, that's a good question. Actually,
I don't know.
I don't think we know the
Yeah.
answer to that. I'm sure it's probably multifactorial. So, you know, if you're obviously getting hypoxic, and there's some data, I showed some data suggesting that the hypoxia correlates with atrial fibrillation risk in these patients.
Right.
And clearly that's got to be part of it. But even the arousals themselves, you know, you can get sympathetic surges without desaturation, which can drive high blood pressure. That can drive, you know, some of the underlying molecular changes that we know that occur in these patients, you know, where you can get free radical generation, where you can get changes in nitric oxide, those sort of things. And those are not necessarily all related just to hypoxia. So it's probably more than one.
All right. So the other is the silo effect between neurology and sleep apnea. This idea about, because we had the same sort of issues over at university hospitals, and they're part of Sleep Smart, but I don't know what the relative enrollment is and the enthusiasm for enrollment really is among academic medical centers with that even are participating. Do you have a sense of that? Because in full disclosure, I'm one of the safety people, but I don't really get to see the enrollment goals.
What do you mean in terms of the number of centers that are academic versus community?
Yeah, that are active, right? Academic and you know, just their enthusiasm for doing this.
No, I think there's enthusiasm. The whole thing, a big part of this, the problem was that this study started up just prior to COVID hitting. I'm impressed that they've already, you know, got 350 some patients randomized already. I mean, I'm sure it's behind the anticipated pace, but you know, most sites got knocked offline with the pandemic, and a lot of places are just starting to come back online now. So I think they're certainly doing better than the LOFT study. I think they'll be able to hopefully meet their goals, but it's probably going to take longer than anticipated originally. Because you know, some sites have had to do tricks where they have to go, you know, they've been doing the auto PAPs on patients at home, you know, and you got to have someone run out to do that. It is, it's difficult.
But on the flip side, it's interesting that, you know, when you, the idea, what you said was you come in with one primary acute illness and then another chronic illness sort of pops its head up. And yet we do a bunch of things that inconvenience patients if they have acute disease. Most acute, I guess they know it's going to end. If you break your leg, you get a cast on your leg, and that's right. Pretty, all sorts of things to do. I think it's really an expectation more than
yeah. Well, and we see that a lot in the preoperative arena too. You know, patients coming in, I'm getting my gallbladder taken out. What? I have sleep apnea. What? Can I just get through my surgery and recover from this, and then I'll deal with my sleep apnea? It's like, well, you know, you want to get through your surgery safely, maybe you should get this addressed first. And same sort of thing with the strokes. The patients, I think you're right. There's some expectation. There's some communication, education gaps. And part of the problem here, I think we've had, you know, our success rate has been so poor, but that's because we're leaving the hands of the PM&R docs and the RTs. They're not the sleep docs, and not the sleep techs to really, you know, go over and hammer home how important this is to get this treated.
But going back to your first sort of series of slides, even if you've had an established stroke, and this, say for instance, theoretically, that this study really doesn't show much, it still doesn't preclude the idea of making a diagnosis and therapy that might have some sort of outcome on either prevention or rehabilitation at a later date, because there's now longer sets of rehabilitation management profiles after 1 year and 2 years of stroke. So
yeah. Well, the whole ideal thing is to get them identify and treat them before they have their stroke, but we're a long ways from that.
yeah. Well, I took care of one person who was pretty sad. He knew he had sleep apnea. He knew he had hypertension. He knew he had this, and he did have a stroke, pretty bad stroke, that limited him from being a surgeon. And he just fought CPAP for the next 2-3 weeks until he sort of got into it and realized it was important. So there's a difficulty in trying to implement our current therapy. It'd be interesting with a CNAP, and that won't start until second quarter of next year.
Yeah. I think the biggest concern, again, like I mentioned, that is you got to make sure all these patients should have carotids, but you got to make sure those are clean.
Yeah, well, that's part of the CNAP protocol.
Yeah.
You got to be aware of that. It's going to be a central, and it's also going to be at 6 months. It's going to be repeated. So it's
yeah, that'll be interesting data to see.